Welcome to MRCPology channel for quick review, understanding of the topics, and a stepwise approach to the PACES exam. Let us begin with an overview of what we are going to understand in this video. Normal movement is not produced by the motor pathway alone. The motor cortex and corticospinal tract may send the command, but that command must be selected, refined, coordinated, and continuously corrected. Three major control systems help to achieve this. These are the basal-ganglia, the cerebellum, and sensory feedback. The basal ganglia help us select the movement we want and suppress movements that are unnecessary. The cerebellum checks whether the movement being performed matches the movement that was intended. Sensory feedback tells the brain where the body is, whether balance is being maintained, and whether the movement needs further correction. When these control systems are disturbed, different abnormal movements appear. Basal ganglia dysfunction may cause too little movement, as in bradykinesia, or too much unwanted movement, as in athetosis, chorea, ballismus, and dystonia. Abnormal oscillation within motor control loops may produce tremor. Cerebellar dysfunction may produce inaccurate movement and intention tremor. Loss of proprioceptive, vestibular, or visual feedback may produce imbalance and sensory ataxia. The overall message is simple. First, identify whether the movement is reduced, excessive, irregular, sustained, or rhythmic. Then use the character of the movement to decide which control system is most likely to be affected. Let us first understand the basal ganglia. The basal ganglia do not directly contract the muscles. Instead, they influence the motor cortex through complex connections involving the thalamus. Their role is to help the brain choose the desired motor program, initiate it smoothly, and suppress competing motor programs. For example, when you decide to reach for a cup, the nervous system must activate the muscles required to move the arm towards the cup. At the same time, it must suppress unnecessary movements of the other arm, the face, the trunk, and the legs. The basal ganglia help the intended movement to emerge clearly while unwanted movements remain inhibited. When basal ganglia activity excessively suppresses the desired movement, the patient may develop bradykinesia. Bradykinesia means slowness and progressive reduction in the speed and amplitude of voluntary movement. It is an important feature of Parkinsonism. At the other end of the spectrum, failure to suppress unwanted motor programs produces excessive involuntary movements. Depending on their speed, amplitude, distribution, and duration, these movements may be described as athetosis, chorea, ballismus, or dystonia. The basal ganglia also participate in motor loops involving the cortex and thalamus. Abnormal rhythmic activity within these loops may contribute to tremor. Now consider the cerebellum. The cerebellum acts like a quality control system for movement. The motor cortex sends out the intended movement. The cerebellum receives information about that intention and compares it with sensory information describing the movement that is actually occurring. It then makes rapid adjustments to the force, timing, direction, and range of the movement. This allows an action to remain smooth and accurate. If the cerebellum is dysfunctional, the patient may overshoot or undershoot a target. This is called dysmetria. The patient may then make repeated corrective movements while trying to reach the target. These corrections become increasingly obvious as the finger approaches the target and may appear as an intention tremor. Sensory feedback is the third essential system. Proprioception tells the brain about joint position and limb movement. The vestibular system provides information about head position and acceleration. Vision provides external reference points. Together, these systems maintain posture, balance, and coordinated movement. If proprioception is impaired, the patient may become dependent on vision to know where the limbs are. The patient may appear relatively stable while the eyes are open, but becomes markedly unsteady when the eyes are closed. This is the basis of a positive Romberg test and supports sensory ataxia rather than primary cerebellar ataxia. With that overview in mind, let us move to the athetosis, chorea, and ballismus spectrum. These movements can be considered along a spectrum of increasing speed, amplitude, and proximal involvement. Athetosis is usually slow and distal. Chorea is faster, brief, and irregular. Ballismus is very rapid, violent, and predominantly proximal. A useful sequence is athetosis, then chorea, then ballismus. Slow and distal movements progress conceptually towards moderate irregular movements and then towards fast, violent proximal movements. Athetosis consists of slow, continuous, writhing movements. These movements are often most obvious in the fingers and hands. They may look snake-like because the fingers repeatedly change position in a smooth but uncontrolled manner. The word athetosis may be remembered by linking it with slow, sloth-like movement. It is sometimes described as slow chorea. However, unlike the brief, fragmented movements of typical chorea, athetotic movements are more continuous and flowing. Chorea consists of brief, irregular, unpredictable, non-rhythmic movements. The movements appear to flow from one body part to another. They may affect the face, shoulders, trunk, arms, hands, and legs. The term chorea comes from a word associated with dancing. A useful memory hook is to imagine someone dancing unpredictably when the chorus begins. The movement does not repeatedly follow one fixed pattern. One movement appears, disappears, and is replaced by another movement somewhere else. Ballismus refers to large amplitude, rapid, violent, flinging movements. These movements mainly involve the proximal limbs, such as the shoulder or hip. The movement may resemble the forceful launch of a ballistic missile. Ballismus can therefore be understood as severe, explosive chorea. The patient may throw an arm or leg suddenly and with considerable force. This can interfere with mobility, feeding, dressing, and personal safety. Hemiballismus means that the ballistic movements affect one side of the body. It classically results from a lesion involving the contralateral subthalamic nucleus or its basal-ganglia connections. For example, violent flinging movements of the left arm and left leg suggest dysfunction within the right subthalamic region or its connected motor network. In practice, vascular lesions are an important cause, although metabolic and other structural causes are also possible. The spectrum can be remembered with one simple sentence: athetosis writhes, chorea dances, and ballismus throws. We now come to dystonia. Dystonia is produced by sustained or intermittent muscle contractions. These contractions cause repetitive, pattern twisting movements or abnormal postures. The word patterned is important. Unlike chorea, which is irregular and unpredictable, dystonic movement often pulls the body repeatedly in a similar direction. The neck may rotate to one side. A foot may invert. A hand may assume an abnormal posture during writing. The eyelids may close forcefully and repeatedly. Dystonia may be painful, particularly when sustained muscle contraction places stress on joints and soft tissues. It may also worsen during voluntary movement. For example, a patient may have relatively little abnormal posturing at rest, but the dystonia becomes obvious when the patient walks, writes, speaks, or performs another specific task. The underlying mechanism involves dysfunction within the basal ganglia and the wider sensory-motor network. Normally, the nervous system activates the muscles needed for an action and inhibits surrounding muscles that are not required. This focused inhibition is sometimes called surround inhibition. In dystonia, inhibition is reduced. Muscles that should remain relaxed become active. Agonist and antagonist muscles may contract together. For example, muscles producing flexion and muscles producing extension may become active at the same time. The unwanted contraction may also spread into nearby muscles. This is called overflow. The combined result is repetitive twisting and an abnormal sustained posture. The mechanism can therefore be remembered as follows. Basal ganglia or sensoromotor network dysfunction leads to loss of inhibition. This allows unwanted muscles to contract together. Overflow develops. The body part twists and may remain held in an abnormal position. The memory hook is simple. Dystonia twists and holds. We now move to tremor. Tremor is a rhythmic, repetitive, to and fro oscillation of a body part. It is produced by alternating or sometimes synchronous contraction of agonist and antagonist muscles. The word rhythmic is the key distinction. In chorea, the movements are irregular and unpredictable. In tremor, the movement repeatedly occurs around the same axis. For example, the hand may repeatedly move from side to side, or the forearm may repeatedly pronate and supinate. The movement has a recurring pattern, even when the frequency and amplitude vary. Tremor usually reflects abnormal oscillation within a motor loop. This may involve the cerebellothymocortical loop, the basal ganglia loop, or peripheral and mechanical factors. A cerebellar tremor is usually most evident during a targeted movement. As the patient approaches the target, dysmetria leads to repeated corrective movements. This produces an intention tremor. A tremor associated with basal ganglia dysfunction may be most evident at rest, as in Parkinsonism. However, tremor classification should always be based on the clinical activation condition. Ask whether the tremor occurs at rest, while maintaining posture, during movement, or specifically near a target. Peripheral and mechanical oscillations can also contribute to tremor. Every limb has a degree of natural mechanical oscillation. Enhanced physiological tremor may become visible during anxiety, fatigue, fever, thyrotoxicosis, hypoglycemia, or stimulant exposure. The memory hook is that tremor oscillates. We can now focus specifically on chorea. Chorea is an involuntary hyperkinetic movement disorder. Hyperkinetic means that there is excessive movement. The movements are brief, irregular, non-rhythmic, dance-like, and unpredictable. The movements often appear to flow from one body region to another. A patient may raise an eyebrow, turn the head, shrug a shoulder, flex the fingers, and suddenly move one leg. There is no fixed sequence, and the same movement is not repeated regularly around one axis. Some choreiform movements may appear semi-purposeful. The patient may incorporate an involuntary movement into an apparently voluntary action. For example, an involuntary movement of the arm may be converted into touching the hair or adjusting clothing. This can make mild chorea difficult to recognize. The core mechanism is reduced inhibitory control of unwanted motor programs. Basal ganglia circuit dysfunction reduces the normal suppression of unnecessary movement. As a result, excessive and random motor activity reaches the cortex and produces choreiform movements. To understand this more clearly, we need to revise the classical indirect pathway of the basal ganglia. The indirect pathway normally helps suppress unwanted movement. The sequence begins in the striatum. The striatum inhibits the external segment of the globus pallidus, which is called the GPE. The GPE normally inhibits the subthalamic nucleus. Therefore, when the striatum inhibits the GPE, the subthalamic nucleus becomes relatively disinhibited and more active. The activated subthalamic nucleus excites the internal segment of the globus pallidus, called the GPI. The GPI then increases its inhibitory output to the thalamus. When the thalamus is inhibited, it provides less excitatory stimulation to the motor cortex. This suppresses unnecessary movement. So, in simple terms, the normal indirect pathway acts as a brake on unwanted motor activity. In the classical model of chorea, there is relative underactivity of this indirect pathway. Striatal dysfunction, particularly involving inhibitory GABAergic medium spiny neurons, leads to reduced inhibition of the GPE. The GPE then becomes excessively active and produces greater inhibition of the subthalamic nucleus. The underactive subthalamic nucleus provides less excitation to the GPI. The GPI therefore sends less inhibitory output to the thalamus. The thalamus becomes relatively disinhibited and sends excessive excitatory output to the motor cortex. This results in excessive cortical motor activity and produces choreiform movements. The full sequence is therefore, striatal dysfunction leads to less inhibition of the GPE. The GPE overinhibits the subthalamic nucleus. The GPI becomes less active. The thalamus is disinhibited. Cortical motor output increases. Chorea appears. This is a very useful model for understanding chorea, although real basal ganglia networks are more complex and involve multiple interacting pathways. We will now discuss the common causes of chorea. It is helpful to arrange them according to the clinical context, rather than trying to memorize one long, disconnected list. The first group includes genetic and degenerative disorders. Huntington disease is one of the most important inherited causes. It is an autosomal dominant neurodegenerative disorder. Chorea is commonly associated with psychiatric disturbance and progressive cognitive decline. The caudate nucleus is prominently affected. A patient may initially present with subtle fidgeting, emotional or behavioral change, depression, irritability, impaired judgment, or deterioration in work performance. Over time, the chorea becomes more obvious, and cognitive and functional impairment progress. Family history is very important, but its absence does not completely exclude the condition. Family history may be unknown, relatives may have been misdiagnosed, or the family may be small. Neuroacanthocytosis refers to a group of rare disorders in which neurological dysfunction occurs in association with abnormally shaped red blood cells called acanthocytes. Patients may have chorea, dystonia, behavioral change, neuropathy, seizures, self-injurious tongue or lip biting, and feeding difficulties. Wilson disease is an important and potentially treatable cause, particularly in a young person. Abnormal copper accumulation can affect the liver, basal ganglia, and other organs. The neurological presentation may include tremor, dystonia, chorea, dysarthria, abnormal behavior, or Parkinsonian features. Clues include liver disease, psychiatric symptoms, a young age, and Kayser-Fleischer rings. The next group includes autoimmune and post-infectious causes. Sydenham chorea is classically associated with the preceding group A streptococcal infection. Immune cross-reactivity affects basal ganglia structures and produces involuntary movements. It usually occurs in children or adolescents and may develop weeks or months after the initial infection. The patient may have emotional lability, hypotonia, motor impersistence, handwriting deterioration, a milkmaid grip, and darting movements of the tongue. Because Sydenham chorea is a manifestation of rheumatic fever, the clinician must assess for evidence of cardiac involvement and other relevant features. Systemic lupus erythematosus and antiphospholipid syndrome may also cause chorea. The mechanism may involve immune-mediated basal ganglia dysfunction, vascular injury, or both. In this context, look for systemic clues. These may include rash, joint symptoms, thrombosis, recurrent pregnancy loss, cytopenias, renal involvement, or other neurological features. There is also a separate video on this YouTube channel containing a picture mnemonic presented as a simple sketch for remembering the causes of chorea. Learners who prefer pictorial memory can look out for that video and use the sketch for rapid revision. The next group includes vascular, metabolic, and drug-related causes. A stroke involving the basal ganglia, subthalamic region, or connected motor pathways may produce acute chorea or ballismus. Sudden onset is the major clue. A patient who develops unilateral chorea or hemiballismus over minutes or hours should be assessed urgently for a vascular lesion. The involuntary movement will usually affect the side opposite to the lesion. Hyperthyroidism may enhance motor excitability and produce tremulousness, restlessness, and occasionally chorea. Look for weight loss, heat intolerance, sweating, palpitations, goiter, and eye signs. Abnormal blood glucose is another important metabolic association. Hypoglycemia can cause a wide variety of neurological manifestations, including abnormal movement. Non-ketotic hyperglycemia may produce acute or subacute unilateral chorea or hemiballismus. Imaging may show characteristic abnormalities in the contralateral basal ganglia. The clinical context often includes poorly controlled diabetes and markedly elevated blood glucose. Medication review is essential. Levodopa can produce dyskinesia in patients with Parkinson's disease, particularly after prolonged treatment. These movements may include choreiform and dystonic components. Antipsychotic medication can produce tardive dyskinesia after prolonged dopamine receptor blockade. The movements often involve the mouth, tongue, jaw, face, trunk, or limbs. Repetitive chewing, lip smacking, tongue movements, and chorioathetoid limb movements may be seen. Some anticonvulsants can also produce abnormal involuntary movements. Cocaine and other stimulants may cause excessive motor activity, agitation, stereotype movements, or choreiform movements. When assessing the cause, always combine the movement pattern with the patient's age, speed of onset, medication exposure, family history, metabolic context, psychiatric features, cognitive changes, and associated neurological signs. A child with chorea after a streptococcal illness suggests Sydenham chorea. A young adult with liver disease, psychiatric change, dystonia, or tremor raises concern for Wilson disease. A middle-aged patient with progressive chorea, behavioral change, cognitive decline, and an affected parent suggests Huntington disease. Sudden unilateral chorea suggests a structural or vascular lesion. Chorea in a patient with poorly controlled diabetes suggests non-ketotic hyperglycemia. Orofacial movements in a patient taking long-term antipsychotic medication suggest tardive dyskinesia. We now come to the clinical features of chorea. The movements are brief, irregular, unpredictable, and non-rhythmic. They may appear semi-purposeful because the patient tries to disguise or incorporate them into voluntary actions. Chorea generally becomes more obvious during stress, emotional activation, or voluntary movement. It usually reduces substantially during sleep. During inspection, observe the patient before beginning the formal examination. Look at the face, tongue, shoulders, hands, fingers, trunk, and legs. Mild chorea may be visible as restlessness, repeated facial movements, irregular finger movements, or an inability to remain still. Do not immediately assume that the patient is anxious or simply fidgeting. Observe whether the movements are truly irregular, unpredictable, and flowing from one body region to another. Motor impersistence is an important associated feature. Motor impersistence means an inability to maintain a voluntary muscle contraction or posture. The patient understands the instruction and has sufficient power, but cannot sustain the action steadily. This occurs because unstable basal ganglia output interferes with the maintenance of a consistent motor program. One classic sign is the milkmaid grip. Ask the patient to grip your fingers firmly. Instead of maintaining a steady grip, the patient repeatedly tightens and releases the grip. It feels as though someone is rhythmically milking, although the variation itself may be irregular. Another sign is the darting tongue. Ask the patient to protrude the tongue and keep it out. The patient is unable to maintain tongue protrusion. The tongue repeatedly withdraws or moves back into the mouth. The patient may also drop objects because sustained grip is impaired. This is not necessarily due to weakness. It may be caused by an inability to maintain the required motor output. In PACES, it is important to distinguish motor impersistence from true weakness. Test power carefully. Observe the movement. Ask whether the patient can generate normal force but cannot sustain it. Gait may also be affected. Random movements of the limbs and trunk disturb the consistency of each step. The gait may appear fidgety, dance-like, lurching, or unstable. The patient may suddenly flex a knee, rotate the trunk, swing an arm, or alter the direction of a step. These movements are superimposed on the underlying voluntary gait. By the time gait is examined, the clinician may already have observed irregular facial, limb, or truncal movements during inspection. Motor impersistence may already have been demonstrated through the grip or tongue examination. Gait assessment then shows the functional impact of the abnormal movement and strengthens the clinical impression of a generalized choreiform disorder. During the examination, also look for clues to the cause. Assess cognition and behavior when Huntington disease is possible. Look for dystonia, tremor, dysarthria, and hepatic clues in Wilson disease. Look for carditis or a relevant post-streptococcal history in suspected sydenham chorea. Examine for systemic autoimmune features when lupus or antiphospholipid syndrome is possible. Also consider whether the movement is pure chorea or part of a mixed movement disorder. A patient may have chorea combined with dystonia, athetosis, tics, myoclonus, tremor, or Parkinsonian features. We now move to diagnosis. The diagnosis of chorea itself is mainly clinical. The clinician identifies the characteristic movement and then investigates the underlying cause. Begin with a detailed medication and substance history. Ask about prescribed medication, recent dose changes, long-term antipsychotic exposure, Parkinson medication, anticonvulsants, recreational drugs, and over-the-counter preparations. Take a careful family history. Ask about involuntary movements, psychiatric illness, dementia, unexplained behavioral change, suicide, institutional care, or relatives who died without a clear neurological diagnosis. Perform a full neurological examination. Define whether the chorea is focal, unilateral, segmental, or generalized. Look for dystonia, rigidity, bradykinesia, ataxia, eye movement abnormalities, neuropathy, pyramidal signs, cognitive impairment, and motor impersistence. Cognitive and psychiatric assessment is particularly important when Huntington disease or another neurodegenerative disorder is suspected. Depression, irritability, apathy, impulsivity, psychosis, executive dysfunction, and impaired judgment may be clinically significant. Blood tests should be directed by the clinical context. They may include glucose, electrolytes, calcium, liver function, renal function, thyroid function, and other metabolic investigations. In a younger patient, investigate for Wilson disease with appropriate copper studies and ophthalmological assessment. The exact interpretation of copper investigations may be complex, so results should be considered together rather than in isolation. Autoimmune and infective tests should be requested when supported by the history and examination. These may include investigations for lupus, antiphospholipid syndrome, or recent streptococcal infection. MRI of the brain is useful when the onset is sudden, unilateral, rapidly progressive, atypical, or associated with other focal neurological signs. It may identify stroke, tumor, demyelination, inflammation, or a basal-ganglia abnormality associated with metabolic disease. Genetic testing may be appropriate when Huntington disease is suspected. Testing should be undertaken with proper counseling because the result has important psychological, familial, reproductive, and insurance implications. The diagnostic approach can therefore be summarized in 3 questions. First, is this truly chorea? Second, is the onset acute, subacute, or chronic? Third, which clinical context best explains it? Genetic, autoimmune, vascular, metabolic, drug-related, or another neurological disorder? Finally, let us discuss treatment. The first principle is to treat the underlying cause whenever it is reversible. Correct hypoglycemia urgently. Improve glucose control in non-ketotic hyperglycemia. Treat thyrotoxicosis. Review and discontinue an offending drug when safe and appropriate. Manage stroke according to the vascular diagnosis. Treat autoimmune or infective disease with specialist guidance. Identify Wilson disease early because disease-specific treatment can significantly alter the outcome. Symptomatic treatment is considered when chorea causes functional impairment, injury risk, distress, sleep disturbance, difficulty eating, difficulty walking, or social embarrassment. One important group of medicines is the vesicular monoamine transporter type 2 inhibitors, usually called VMAT2 inhibitors. Examples include tetrabenazine and deutetrabenazine. These medicines reduce the packaging and release of monoamines, particularly dopamine, from presynaptic nerve terminals. This decreases excessive dopaminergic motor signaling and can reduce chorea. However, treatment must be individualized. Tetrabenazine can worsen depression, cause sedation, produce Parkinsonism, or cause other adverse effects. This is particularly important in Huntington disease because depression and suicide risk may already be increased. Deutetrabenazine has a modified pharmacokinetic profile and may be easier for some patients to tolerate, but it still requires careful assessment and monitoring. Dopamine receptor blockers may also reduce chorea. Examples include risperidone, olanzapine, and haloperidol. These medicines reduce dopamine receptor signaling and dampen excessive basal ganglia cortical motor output. They may be particularly useful when chorea is accompanied by agitation, psychosis, severe behavioral disturbance, or sleep disruption. However, they can cause sedation, metabolic adverse effects, Parkinsonism, acute dystonia, akathisia, and tardive movement disorders. The choice must therefore be based on the overall clinical picture. In Huntington disease, do not treat the movement in isolation. Consider the severity of the chorea, the degree of functional impairment, depression, suicide risk, psychosis, cognitive status, swallowing, falls, weight loss, and the patient's priorities. A patient with mild chorea that is not causing distress may not need immediate symptomatic medication. In some patients, suppressing the movement too aggressively can worsen rigidity, bradykinesia, swallowing, balance, or general function. A patient with prominent psychosis or behavioral disturbance may benefit from an antipsychotic that also reduces chorea. A patient with significant depression or suicide risk requires particular caution with dopamine-depleting therapy. Multidisciplinary care is essential. Physiotherapy can support gait, balance, and fall prevention. Occupational therapy can help with daily activities and home adaptations. Speech and language therapy can assess communication and swallowing. Dietetic support is important when weight loss or feeding difficulty develops. Psychological and psychiatric care may be required for both the patient and family. In PACES, a clear summary would be, this patient has an irregular, non-rhythmic, flowing hyperkinetic movement disorder consistent with chorea. I would assess for motor impersistence, gait disturbance, cognitive and psychiatric involvement, and associated neurological signs. I would then investigate the cause according to the age, onset, medication history, family history, metabolic context, and systemic features. The final memory structure is straightforward. The basal ganglia select movement and suppress competitors. Failure of suppression produces unwanted movement. Athetosis writhes, chorea dances. Ballismus throws. Dystonia twists and holds. Tremor oscillates. For chorea specifically, remember that the movements are brief, irregular, unpredictable, and flowing. The classical indirect pathway model explains how reduced inhibition of the thalamus leads to excessive cortical motor output. The cause is then identified using the age, timing, family history, medication exposure, metabolic clues, autoimmune features, imaging, and targeted genetic assessment. Do subscribe to the channel for further videos.